Okay. I want to thank everyone for being here, and I want to thank especially whoever was involved in asking me to be here, because most of the time people don't want to hear what I have to talk about, and that's because they're not going to be financially rewarded for seeing these folks. So it's really a privilege for me to come and talk, and really what I want to do, we started 35 years ago trying to find supports for these individuals. There were no supports in our community, and it turns out there still are not in most. And what I hope to do was just give you some information so you're not having to reinvent the wheel as you go try to see these individuals. The two issues are establishing a community that will support you as you try to support the individuals, and then also to show you how to develop an office to do that. So, hold on, okay. So who am I? I'm a primary care doctor, and anything that I tell you about, if you're in the primary care field, you can do whatever I have done. Again, there's no medical supports in most communities, so you have to try to figure out how to do that. The mothers and other agencies that supported these individuals, myself, the state, we all worked together and are still working together to try to do this. Are we advancing or not? Okay. Well, my idea today was to help you have at least some background in how to develop these issues. So I apologize. This is going to be one of those presentations where the guy runs through it and you're wanting to get out of here, but I really wanted you to have really the handouts that'll be left so that you'll have this information for the future. How do we get here? There were three transitions that brought us here. The first was the transition from the pediatric office to the primary care office. When I started, that never happened. The people didn't live long enough to get to the primary care office. The second transition is the transition from institutional living, where they all were living, into community living. The third transition was behavior management transition, and I'll try to get to as many of these as we can. Transitioning to adult primary care. The developmentally delayed individuals, they had a limited lifespan. Pediatricians took care of them. As their lifespans increased, the pediatricians still took care of them. The primary care doctors did not feel comfortable with them because they had never been exposed to them before. So we had pediatricians that were taking care of people in their 50s and 60s and really didn't know what to do with them, okay? 35 years ago, when I was sent across the country to find the experts, I found three of them, and they were all three pediatricians. Winston-Salem Medical School tried to make a difference. They developed a fellowship where primary care doctors could become experts in this field. It didn't get very far because they realized that these doctors would never be able to put bread on their table, okay? There's no reimbursement when it comes to seeing these folks. Transitioning into the community. All these folks, at some point, they were in developmental centers, okay? And it became obvious that their restricted development was because of the institutions they were in. And we wondered what would happen if we put them in a normal environment. So the normalization you may hear about down the road, it's not about trying to make the people normal. That wasn't ever going to happen. It's about what happens to them when you put them in a normal environment. And when you do, everything changes, okay? Willowbrook Developmental Center, it was the best thing that ever happened to this group of people, and it was the worst thing that ever happened to them. It was a center that devoted itself just to the developmentally disabled people in New York, but it was markedly underfunded. And it just became a warehouse for these individuals with very, very poor things going on as far as supports were, because they didn't have any money really to support these individuals. The U.S. Department of Justice came into every single state and insisted that all these individuals come out of their developmental institutions and into the community. If you're in any state besides Missouri, what you'll probably run into is what's called class members. And that's because they all came out of the institutions with class action suits. Missouri was one of the few states that that was not necessary in. When the Justice Department came here in 2004, Missouri apparently just said, you know what, we're going to run with this idea and do the things that need to be done. And to my knowledge, they never had to have a class action suit against them. In spite of that, there still are no communities that I'm aware of that really have all of the supports that are needed for these individuals, especially medical supports. So behavior management transition, initially this is how we took care of the folks. They either ran freely in an institution or they were chained to a pole, and there was nothing else that could be offered them. The big thing that happened was that medicines were developed that allowed these people to get their chains off. Today, when you hear people talk about these medications, they sound like the medications from hell, but they really weren't. They allowed these people to get out of these institutions, medicines like Thorazine. Today, Thorazine is still used because it may be the only medication that works for a particular individual. Behavior management transitions, 16th to 17th century, they were all in chains. Late to early 20th century, we had chemical management. The chemical management, though, was replaced by behavior management because chemical management was all about being in a medical straitjacket, having the person sitting there and just being unresponsive, you know, drooling on themselves, because we didn't really know how to use the medications when we first started, okay? So the Justice Department came in and said chemical management was worse than electric shock therapy. And that's when they got involved. One of the greatest things that happened was in the 1970s. And this is when we found out what the neuroreceptor was. That place on the nerve cell in the brain where a chemical has to attach in order to affect some sort of change. This allowed us to take individuals and find individuals that had specific neurologic chemical imbalances and change those imbalances with medications. This way they were allowed to just be the normal cells, but their behavior was under control, okay? This is where you become a player if you choose to, and the reasons why you would not choose, first is behavior. Second is if somebody comes to your facility, if they got a broken leg, you want to be able to get an x-ray. When I started, no one would do an x-ray on our folks. They told us, don't send your patients back here. So, you know, who wants to see a patient if they can't get the supports they need? The next one was financial. Still today, that's not going to happen. If you are treating these folks, you're doing somebody a favor, okay? Another issue that I ran into was a lot of people said, Dr. Prater, why are you bothering with these people? Don't they have mental retardation? Shouldn't we just allow them to have the natural course of their lifetime? What I had to do was tell everybody what the parents told me. And today, I still have to do this every day. When I have a patient that winds up in the intensive care unit, the intensivist calls me and says, Dr. Prater, your patient's up here, he has mental retardation, and he does not have a do not resuscitate order. What I have to tell him is what I expect you to do for this individual is everything that you would do for me if I came to your institution. And then if a terminal issue becomes apparent, we can talk about a do not resuscitate order then. Even today, a lot of physicians have a hard time swallowing that idea. Setting up a supportive community, what do providers want? First thing they want is they want to feel safe, and they want their staff and their patients to feel safe. And believe me, we can tell you exactly how to do that. They want to know that they can get the supports they need, an x-ray if they need one. And they want financial reimbursement, but that's not going to happen. Setting up a supportive community, first thing we had to do is demonstrate that the behavior would be controlled if they came to these different places, okay? We had to show that the most informed caregiver would always be there, so they weren't having to figure out why they were there and what they needed to do. All necessary data is always provided. Every single time one of these individuals come to my office, they bring the medication administration record. That's the record that shows the signatures and the times that the medicines have been given. I don't want a sheet showing me what their medications are. Those sheets are usually not right. And if they brought me somebody who's having a behavior problem, I want to know that it's not because somebody forgot to give them a medicine or somebody gave them a medicine that belonged to somebody else, okay? So they have to have the medication administration record. History is available, and we'll talk about that. Reimbursement issues are time sensitive, and we really want to try to help the people that we're referring people to by limiting the time that's going to be necessary for them to see the patients. And I'm not sure what happened to some of these slides. I think they're out of place. But big deal, I refer somebody to a specialist, okay? First of all, if that specialist is willing to see my patient, I need to mark him down as somebody that I want to keep. But I also need to make a way that I know he's going to see my other patients and he's going to continue to see this one. A specialist is never going to be reimbursed for the time they spend. So I try to minimize the amount of time they have to spend. When they go to this specialist, they have a history with them with everything that specialist would want to know. There's a referral note. They have their MAR. And if I think they're going to need an X-ray or a lab or an MRI, I'll go ahead and order that. Because if the specialist has to order it and then have them back, he's not going to get reimbursed for either of those two visits. If I can minimize the number of visits, then I can improve the rapport I've got with the specialist that I'm using. You want to familiarize yourself with any community supports that are available, okay? And I'm just going to list these up there. They'll be on your handout, but all of these are important. One that's up there, though, is pharmacies willing to do unit dosing. This is really important for these individuals because if they are especially if they're in a group home situation, that's the only way that they'll be able to have their medications done appropriately. Physical, occupational, speech therapy, and home health care, these are all things that these individuals will need. And if they're not available, then, we had to develop them, okay? How do you develop them? Trial and error. We sent them to doctors. If they said, don't send your patients back, we kept finding doctors that would see our patients. A lot of times it was doctors who also had people in their families with developmental issues, okay? Sometimes, though, when all else fails, we had to use something. We didn't have to do this very often, but especially with hospitals, x-ray departments, and so forth, we had to use shame and we had to play hardball. And that's when I brought somebody from the newspaper, went to the administrator's office of that hospital, and said, we want you to help us write an article that's going to explain to the readers of this newspaper why you do not want to serve these individuals. That only took one visit wherever we went. But I'm telling you, in your community, you're going to have to do whatever's necessary to get the support of these individuals if you really want to see them. And you're not going to be able to see a lot, not of the markedly involved. But if everybody in this room would take 2 or 3, we wouldn't be having a problem with finding support for them. We found the experts. They sent me across the country. I found 3 pediatricians. I came back to Chattanooga and I found experts. Does anybody here have somebody in their family with a developmental disability? Oh, wow. Okay, great. Who were the experts that I found?
I'm not sure.
What did you say?
My parents.
Yes, your parents. When I came back, this isn't working for some reason, but when I came back, it's not advancing, yeah.
Yeah, hold on a second.
Anyway, I found the experts, okay? And in this slide is a picture of 2 women, 2 parents that taught me most of what I'm teaching you today and most of what I needed to learn how to support these individuals. They were absolutely wonderful. The first thing that we learned in taking care of our patients was we had a golden rule, and that is mom is always right. And she's always right. She may not know what's wrong, but if she says Johnny ain't right, Johnny ain't right. And it's our job to evaluate that person and find out what's going on. Now, another slide that we skipped was a picture of a mom with multiple caregivers, and she was explaining to each caregiver the things to do with her son and the things not to do. If you will simply listen to the parents, or if you have a high-functioning patient, listen to the patient, 90% of your trying to figure out what to do will be already done for you. Okay, so I'm not sure where I am in this thing, but for office setup, you want to prepare your office, and individual support is what you want to know. You know what individual supports are needed for each person. As the experts, again, we established this at our initial encounter, and that's going to be the mom or the caregiver that's been with them the longest. Okay, needed supports. First one is my presentation. How do I present myself to this patient, okay? Do I want to look them in the eye? That may be very important. It may get me knocked out, okay? The caregivers will tell you how you present it to the people. If they're autistic especially, you don't want to get them in a corner. You'll get knocked out like I got knocked out, okay? They will come out fighting, okay? Familiarity. You want them to be able to see familiar things when they come to your office. If you've got personnel that you're used to, it's great to have those personnel there with them. We wore non-threatening clothing. We didn't wear white coats and so forth. Sometimes a particular room is important. Joshua came to us when he was 5 years old. I don't take patients when they're 5 years old. No other doctor in Chattanooga would take Joshua, and his mother was crying, so we said, okay, we'll take Joshua. And the story was, every time he came to a doctor's office, the first visit was perfect. The second visit, he was a hellion. Our first visit, he was perfect. Second visit, he was a hellion. I just walked over to him, I gave him my hand, and I said, show me what you need. He brought me out of that room, into the room next to it. That was the room he was at the first time. That was his room from now on. He's graduated high school. He's a well-known ball player in Chattanooga. He's in college. And all of this, every bit of progress he's made is because people learned to listen to what Joshua said his needs were and what his mother said his needs were. I tell you, if you do that, that takes most of the work out of trying to see some of these folks. Minimum time awaiting is important, and sometimes limited sensory input, but the caregivers or the parents can tell you when this is important. Our initial evaluation, you know, I'm going to do it and I'm going to do it right. And to do that, I have to know every single thing about this individual. So for me, our initial evaluations took 3 visits, okay? And in none of them, we did not take care of any acute issues. If there was an acute issue, they had to go to the emergency room. I can't take care of somebody if I don't know everything about them, okay? Let's see here. Third encounter is when we come up with a plan of how we're going to address the issues we found. So our first encounter, again, no issues, we get acquainted with the individual. The person comes in. If they're moderate to high functioning, they come in, they meet everybody, they're there 5 or 10 minutes and they leave. Then their caregivers stay for the rest of the evaluation, so they're not having to sit through all that, okay? The first thing that we do, and this is extremely important, we get the caregiver or the parent and we let them know that they are the ones that are absolutely responsible for 2 things. They're responsible for controlling the behavior. If the behavior is not being controlled and we can't see them, they have to make another appointment, okay? They know how to control the behavior. Sometimes they get a little lax and they wind up in our office and there's problems. They never get past the front office, okay? They send them back if they haven't done what they need to do. The second thing that's really important, they're responsible for making the transfers. If they're in a wheelchair, no matter what the issue is, they are responsible for making the transfers. They're the experts, okay? They know if this is a 2-person transfer, a 3-person transfer, and when they show up in my office, they've got those people necessary to do the transfers that need to be done. I'm not going to do them. My personnel's not going to do them. If we try to do it, either the individual is going to get hurt or one of us is going to get hurt, okay? History is taken from the most familiar caregiver. That has to be present at the first visit. If a parent is available, that's really who we need to be talking to. Otherwise, the caregiver that knows the person the best, okay? We have to document the identity of a conservator, and this is important too. Moms are going to come to your office, and they're going to say, my 25-year-old son, I'm the conservator. I've always been the conservator. I'm always the one that tells people what to do. Well, that used to work. It don't work no more, okay? People are finding out that if they're over 18 in most states, they have to have a conservator appointed in a court of law. And believe me, you're going to run into trouble trying to take care of these people if you don't have that, okay? We establish who the conservator is. If they don't have a conservator, we show them how to get one, okay? Conservators' plan of interaction with us is important. We get that determined. We find out who the person is that's going to be responsible for notifying the conservator of any change in treatment, because that has to always be done. That's not going to be me. I don't have that kind of time. So we find the person with our first meeting who's going to do that. It may be a parent. It may be somebody in the residential services where they're living. It may be a social worker. Everybody has a social worker. The state sees to it. It is not a state employee, okay? It's somebody independent of the state because of conflict of interest issues. But they will all have a social worker, and believe me, that may be the second most important tool that you have, because it's that person's job to see that your individual gets anything that you believe they need. And if it requires financial support, then they are to get it from the state, okay? That's their job. What are the expectations of the conservator from me? If it's I'm going to call them every visit, that ain't going to happen. They have to understand how I'm going to get the information to them, okay? First appointment, we always make a lab appointment with the supports necessary. That's the people that need to be with them to get the lab. And it may be that they need sedation. We also document at the first time what sedation has been needed in the past. That may give us an idea when we need it in the future. So I'm not preparing to evaluate an individual with a developmental disability. I'm preparing to evaluate an individual. And anything relative to the developmental disability is add-on information, okay? Take a person with Down syndrome. They've got a set of chromosomes that are messed up. They got 22 other sets of chromosomes. It turns out that as an adult, the family history is critical. And family history out-trumps everything else. If we have a family history of something, it's very clear in the chart that that's something that we need to watch for, okay? Don't handicap yourself. History is going to be the most important tool in your toolbox. I know you've been told that in school, but it's hard to get a handle on that until you get into practice. And I guarantee you, one of my mentors said, if I don't know what's wrong with this individual by the time I finish talking to him, I'm probably not going to know. But I do get up and I examine them because I don't want them going home and saying the doctor never touched me. That's really important with this population. I started seeing adult people, 50s and 60s, and the parents always told me no medical personnel has ever touched him or her since they left the pediatrics office. I had one kid that was on blood pressure medicine and something else, and I asked the parent, how did he get on that if he's not been to a doctor? She said, well, I called my doctor and told him he was in the kitchen standing and jumping up and down and screaming, and his face was red. And they said, he's got high blood pressure, and put him on blood pressure medicine. That was about 20 years before I saw him. So be sure that you make physical contact with the individuals when you see them. All history records are brought to the initial evaluation. What history records? And this is important because I get them all on the first evaluation, or I may not get them. If they've been in a developmental center, I want those records. They'll be the best records I ever get on them, okay? State agencies, if they've interacted with them, I get those records. And then the usual records, hospital records, doctor records, psychiatrist records. These people probably have behavior specialists. I want those records too, and pharmacy records, okay? Initial evaluation, the second encounter. We've had lab drawn, we want to go over that. We've had history taken, we want to go over the pertinent points. And then the third thing is the physical exam, and this is another golden rule. Every time that person comes to me and I have to do a physical exam, they have to be up on the examining table, undressed and in a gown. They come to me and they've been screaming all night. I have to look for everything. Okay, I can't do that if they're in a wheelchair. Okay, they have to be up on the examining table. Putting a plan of support together. The third encounter, like I said, we review the problem list, review the medications. For every medication, that ought to point to a problem, or it shouldn't be on there. Okay, with caregivers' input, we come up with a plan of action. For any plan of action, this is really important, we have to give very clear written instructions before the patient leaves. This person probably has multiple caregivers, okay? I give very clear record of what is to be done, but before they leave, I establish something else. How is this information going to get to the rest of the caregivers? How's the third shift person going to know about this? If I don't do that, they're going to take that information, stick it on the refrigerator, and no one else is going to see it. So I have to always be sure that I've addressed with them a plan that they're going to see every caregiver gets the information. And I'm telling you, the more information I give the caregivers, the better job they're going to be doing. If I tell them why I'm doing a treatment, there's a better chance that they're going to follow through with the treatment that I've ordered. Subsequent encounters, you know, the most important thing, they have to be, the person with them has to be the person that knows the most about them. They come into my office and I say, why are they here? And they say, I don't know, I came in at 8:30 and at 9 o'clock they said, bring them to Dr. Prater's office. What am I supposed to do with that? They never get past the front desk, okay? They have to reschedule, they have to come back, and the person that knows the most about them has to be with them, okay? The other thing that I have to have with them is that data I talked to you about, the medication admission record and anything else that I'm having them collect. Do I need to identify a special syndrome? Okay, when I first started 35 years ago, the answer was, you know, probably not, okay? But with the Human Genome Project and all the other informations we're getting, we have a different answer now, okay? But the first thing is you're not seeing a kid, you're seeing an adult. Mom already knows what the syndrome is, okay? Caregivers, they already know what the syndrome is. But if you have somebody and they don't look exactly right to you, first thing you do is you look at the family, okay? If you look at the family and you don't see a family characteristic that looks like that, then you may want an evaluation. And if you're lucky, you can possibly have a geneticist or a developmental pediatrician in your area that can do that for you. So what if I make a diagnosis? Well, the rest of the family may want genetic counseling based on what I found, okay? And that's the cousins and everybody, all right? The other thing is that information may contribute to the monitoring plan. It can be helpful or it can be very misleading. If a thyroid patient comes to my office, we always check their thyroid every time we draw blood because they're always going to have thyroid problems, okay? For the Downs patients, 100% have Alzheimer's disease under the microscope on their brains, okay? So we have a Downs patient and They start declining at age 50 or 60, which is when they usually start declining. It's really easy to say, oh, that's their Alzheimer's. You better look and be sure there's nothing else going on, because there's multiple issues in that population. A particular one is that's when a lot of them get depression, okay? And depression in that population doesn't look like everybody else's. It shows up as stubbornness. And when I tell parents of that have Down's patients, they laugh at me. They say, he's already stubborn. No, you're going to see a new kind of stubbornness, a mean type of stubbornness. And that's an indication that something has changed, and you probably need to look and see what it is. Frequent issues that we see in this population, one of the biggest is communication skills, but I've got the experts that's going to tell me how I communicate with this individual. Some of them will have their own personal sign language, but if they bring me somebody and they said he's been screaming since 3 o'clock last night, and I have to figure out what's going on, sometimes all I got to do is start moving body parts, you know, and you will find the problem. High pain thresholds. You're going to be told they all have high pain thresholds. Don't pay any attention to that. One person will come to me and I prick their finger and they'll fuss at me for a year, okay? That same person will go outside and play basketball on a fractured ankle. It's not dependable. It's also not dependable when you're starting to look for pain as a possible source of a problem. So it can be a difficult issue. Aspiration, feeding disorders. You know, it's common in this population. People right away want to stop feeding. Don't ever stop the feedings, okay, until you have to. 35 plus years, I've had to stop feedings 3 times, okay? If they're aspirating, there's a great chance that it's positional. A good speech therapist in a swallow study will find the position that you can feed that person in, and they don't aspirate, and it always happens when you check for it, okay? Feeding tubes and keeping people NPO are not really issues anymore, except some people just can't get enough nutrition down to maintain themselves. So sometimes we'll use a feeding tube in order to improve somebody's physical status. I guarantee you, if it's a mom that's been around a while, when you start talking about a feeding tube, she's going to turn green and pass out, because feeding tubes have always meant the end of the road. And we have to explain to them that that's not the case anymore. A feeding tube will probably allow him to live comfortably 35 more years where he won't otherwise, okay? Bowel issues, I guarantee you, the first time we see these individuals, we get this under control. They're going to be coming in your office, there's going to be every kind of complaint available, and the problem is going to be they have bowel problems, they have constipation problems. We clean them out, and I guarantee you, if nothing else will clear them out, milk and molasses enema does 100% of the time. All the caregivers will complain to you, okay? It will clean them out, and then we put them on something that keeps them regular after that. Recurrent pneumonia, recurrent bronchitis, consider aspiration, but don't keep them in NPO, okay? One thing you do want to consider, though, some of these people, if they've been in a wheelchair all their life, they may have developed tracheomalacia, okay, and that is why they're having recurring problems. When I first started at Orange Grove, the first year, I had probably 50 patients I never saw. When I finally did see them, we started looking to see why they were always in the hospital. Tracheomalacia was one of the most common reasons. And so for these individuals, one of the first things I did was have a pulmonologist check them, okay? A simple tracheostomy means they never have to go back to the hospital with pneumonia again. Seizures, I had to become the seizure expert. When you leave today, if you're paying attention, I promise you, you are going to be a seizure expert, okay? If somebody's having a seizure and you don't know what type it is, I can just about guarantee you it's partial complex, okay? I'm a simple Simon. real simple assignment. I have ADD, okay? So you give me a piece of paper with 1,000 seizures on it, and that's not going to get anywhere with me. It doesn't really have to, because it doesn't make any difference. If somebody comes to me and they have seizures, I start them on Depakote. It works for every single seizure. It's the only medicine that does. It may not work for a particular individual, but if you'll notice, it's the one that the neurologists always start with, okay? Seizure classification, I had to keep it really, really simple. I have ADD. The bite that I can take is 3. Give me 4 things, I never get done, okay? So my 3 things in evaluating seizures came to looking at what type of seizure it was, and then classifying it so I always knew what type of seizure it was. And what I came up with was, do they have motor or sensory component? Is their arm jerking or is their arm burning, okay? Do they have a change in sensorium in their mental status? With just that information, I can tell you exactly what kind of seizure it is, and the neurologist 100% of the time agrees, okay? Tonic-clonic, grand mal seizures, both components are very strong. Simple partial, okay? They have an arm that's jerking or they have an arm that's burning, but they do not have a sensorium change. Complex partial, the only thing that makes a complex partial seizure is not the number of things they're doing, it's whether or not there's a sensorium change or not. And that can be pre-ictal, it can be before the seizure, it can be during the seizure, it can be post-ictal. If there is a sensorium change associated with that seizure, it's complex partial, okay? What difference does it make? Probably not much, because you're going to treat it with Depakote anyway. Drop seizures is the other seizures that I ran into, and thank you, darling. The wind beneath my wings. Drop or atonic seizures, not hard to figure out. The kid, drops into his potatoes every time he sits down to eat. I don't know most of the time if they have sensorium changes, but it doesn't make any difference. I'm going to start them all out on Depakote anyway, okay? Pediatric behavioral disorders, 2 types of intervention. I can tell this is not the slides I wanted, but so how much time do we have?
We got another 15 minutes.
Okay, so behavior modification is one thing that you can do. It's one thing that the Justice Department told us we had to do in the 1950s. Good luck with that. Chemical manipulation, that's what they did not want us to do because of the chemical straitjackets. What we have today is something special, and that is we can treat somebody that has a target behavior, okay? I'm going to run through these right quick, but when they want us to do behavioral modification, there's 2 ways. One is the original way. You give them a positive or negative reinforcement that has nothing to do with the individual, okay? The second and the better way, and what we do today, is applied behavior analysis. And that's where we look and see what triggers are in the environment and what the payoff is for the individual. Then we change those 2 things. Autistic individual walks into a room, he always has his blue chair, there's always a fight for that blue chair. You make all the chairs blue or green or brown or something, but you still have to give that individual something for safety, and so you give him a blue teddy bear. And over time, that becomes his security blanket, okay? So you have to change the security blanket for the individual. The chemical interventions we've talked about, the chemical straitjackets, nobody likes us to do those. Specific target behaviors we'll talk about. That's where we actually fix what's broken, okay? Chemical straitjackets, they're still appropriate if somebody is dangerous to themselves or somebody else. And we can use a neuroleptic. They don't like us to do that. You can use sedative hypnotics. They don't like us to do that either, okay? Chemical straitjackets, the neuroleptics, the reason they don't like us to use them is because of their neurologic side effects. There's two types of atypical, of neuroleptics. There's a traditional one, the ones we always have. They block dopamine. All the bad side effects are from blocking dopamine, okay? The atypical ones, they block dopamine and serotonin and allow us less of a dopamine blockade, therefore they have fewer side effects. Side effects, the neurologic side effects, we don't have time to go into, but they're EPS and tardive dyskinesia, okay? And if we have the time, I'm going to make you the expert on that, okay? Well, anyway, EPS. If you don't know which kind of a side effect somebody's having, then they either are having dystonia, EPS, or tardive dyskinesia, okay? Because tardive dyskinesia doesn't have tremor, it doesn't have the bradycardia, the slow walking and so forth, but they do have the muscle tone problems, okay? EPS, they're stuck. Okay, they turn their head, they can't get it away, okay, they're stuck. That's EPS, that has an easy treatment, okay? If they come to you and they're jerking, repetitive jerking of their neck, that's tardive dyskinesia. And good luck with that one. There's not a good treatment. It's on the chart slides here, and hopefully there'll be time that we might be able to come back to that. Chemical straitjackets, the sedative hypnotics, the reason they don't want them, quality of life issues. Also, they're going to quit working after a while, okay? These medicines are going to latch on to neuroreceptors on these cells. Well, what the cell's going to do every time you give them one of these medications, it's going to decrease the number of neuroreceptors. At some point, there's not going to be anything to treat the person with on that nerve cell, okay? It's going to quit working. If you think they had problems before you started the medicine, wait till you stop it, okay? The other issue is dependence. You know there's a dependence issue if you stop it and there's a withdrawal reaction, and these people have that from the sedative hypnotics. So, chronic disruptive behavior, two behavior ideas I want to tell you about. One is acute, one's chronic. Chronic's been there for a long time. We want to look for the target behaviors. Sydney, he was 5 years old when they brought him to see me. Again, I don't see 5-year-olds, but no one else in Chattanooga would see him. And when I saw him, I understood why. He was running around, he couldn't sit down. He was drawing blood and bruising everybody in the room, and he had this unbelievable scream that I'd never heard of before in my life, okay? So what we want to know is, could we find some target behaviors? One was, he looked like he was hyperactive. I told Mom, I'm starting him on Ritalin. She said, you'll stop it in 2 days. Every doctor in town has started him on Ritalin. They stopped it in 2 days. I started him on Ritalin, but I did something no other doctor had done. Again, try to emphasize this in some of the slides, but data collection is so important. I told the teacher, you collect over 30 minutes, 2 different days for 2 weeks, how many times you have to redirect Sydney. Then you do that after I start the medicine. Everybody was in my office saying you have to stop the medicine. I turned to the teacher and said, how many times did you have to redirect them before we started the medicine? She said, I couldn't count that high. How many times are you redirecting them now? I don't have to redirect them at all. So it took care of its target behavior. He's still aggressive, so we went to the aggressive medicine, to the part of the brain that deals with aggression, okay? That's the locus coeruleus. Put him on clonidine, bang, no more aggression, okay? And then the screaming, it could be a seizure disorder, but we also knew he was autistic. And when I saw Sydney, everybody in his room were putting their hands up to their ears as he started screaming, except for Sydney. And it looked like he was an opiate addict, like so many of these autistic individuals become. They become addicted to their own brain's opiates. And that's what Sydney was. I was also medical director at the local treatment center. I put him on the same thing I did my heroin addicts, naltrexone. And until this day, he has not had any of these behaviors except for one time. And that's when somebody decided to give him a drug holiday. I hope you don't do that unless you really know what you're doing. Because when you go back to restart those medicines, when the behaviors come back, you may not be able to recapture those behaviors, and then you're really going to be in a mess, okay? Decreasing the number of medicines. That may be okay if you know how they were started. In Sydney's case, you know, he's on 3 medicines, but every time they restarted, something got better, okay? If somebody is on 6 medicines and for the first 5 they didn't get better, the 6th one they got better, but they're still on all 6, well, maybe you can look at starting to taper some of those early medicines, okay? So we already talked about all that. Can Sydney be maintained in a classroom? This is Sydney in a classroom. That's his teacher. This is many years later, okay? And again, they broke the golden rule. You don't ever fix what's not broken. And for Sydney, they tried to give him a drug holiday, and that was a terrible event, but they recaptured it. What other disorders have target behaviors? Autism and OCD. Autism is stuck. OCD is repetitive. Autistic individual goes to wash his hands. 15 minutes later, he's still washing his hands. You redirect him, he's stuck on the next thing. OCD person, they go back to washing their hands. We can treat OCD. We got medicine for that. We can't treat autism. ADD, we talked about. Temporal lobe seizures, I think we talked about, where I got knocked out. And self-injury behavior, we talked about. Anger management issues, we talked about. Mood disorders. I guarantee you this is the truth, and you're not going to find it written very many places. If you have somebody, they truly have a mood disorder, you're dealing with one thing, okay? You're dealing with REM sleep disorder. And if that mood improves, it's because that medicine improved the REM sleep. Again, I don't have time to go into all that. Post-traumatic stress, these people have a lot of that. Sometimes you'll find a person, place, or sound that triggers their emotions, and you just get lucky if you accidentally find that, okay? If somebody, tick disorders are common also, and they have their own treatments. If somebody comes in, though, and they have a lot of behavior problems going on and they don't have any of these other target behaviors, it's likely to be one of these 3, okay? And then in the last 2, the treatment's the same. You use a neuroleptic. Schizoaffective disorder, I thought I made that term up. I see it's in DSM 5 or 5 now, but schizoaffective disorder really describes anybody who's having a behavior disorder. You look at them and you put them on a neuroleptic and they get better, okay? You have to have that because people are going to come and tell you, I have to have a diagnosis, okay? Every time these medications are started, their caregivers are put through a gauntlet of issues of people trying to find out why are these on these medicines. It's not to stop the medicine, it's to be sure that they're documenting the reason for the medicine. What is it that they have to go in front of? Human Rights Committee, okay. I can't do anything without her, okay. So what's more invasive, fixing what's broken or behavioral straitjacket? What if I told Sydney, I'm going to give you a negative reinforcement if you stand up again? Instead of giving him a medicine that made that bad feeling go away that causes him to be up and jumping all around everywhere. Deciding which neurochemical to use, this may be the most important slide of the day. It never makes a difference. The only difference is you monitor the outcomes. That's going to select the most effective agent, okay? Every psychiatrist will tell you that. We want to monitor for treatment effectiveness, for side effects, and we want to document. That has to be done with every patient that I see when I'm starting them on a medication to help their behaviors, okay? Acute behavior change, you may have to tell me if I run out of time. Acute, huh? You're running out. Okay. Acute behavior change, again, this is important. It's not because their neurochemicals are out of balance. You don't need to go change the medicines that they're already on. You need to find out why they're having a sudden behavior problem, okay? And the chances are it's going to be a medical problem causing physical pain or an environmental problem. The case that's up there is a kid that was throwing chairs through a picture window. His sister brought him to me. He was sitting in a chair drooling on himself and she was crying. He was on 6 neuroleptic agents. They didn't bring him to me before they brought him to the psychiatrist. And checking out what the problem was, he was in a new group home. And this kid, all of his life, he wasn't a kid anymore, he's an adult, this guy all of his life knew that if he had a problem starting, all he had to do was go outside, open the door, stand there for 3 minutes, come back, he was fine. His new house that he was in was on a busy street. Every door was locked. We took him off all of his chemicals, put in a backyard fence, and he did fine, okay? End of life issues, these are all important. I've talked about the do not resuscitate ones. All these others apply for every one of our folks. And I'm sorry I ran over, but are there any questions? How far did I run over?
Looks like you got a minute.
I got a minute left, okay. All righty.